In this final video on GI pathology and lower GI pathology, we're going to look at inflammatory bowel diseases like Crohn's and ulcerative colitis. I'm going to look at diverticulitis, appendicitis, and colorectal cancer, and then we'll talk a bit about hemorrhoids. So IBD, again, don't confuse this with IBS. There are two major types, Crohn's and ulcerative colitis. Both are chronic, relapsing inflammatory disorders. We think they're both autoimmune in nature. And they both exhibit problems in the bowel, but also many what we call extraintestinal manifestations. We already saw that with the dermatitis herpetiformis earlier, also chronic aptostomatitis canker sores. But there can be liver issues, arthritis, skin, eye problems, etc. That all come from IBD. And the major difference between these two is in the location of where it occurs, but also the nature of the inflammatory changes. Again, don't confuse this with IBS. Now, there's a lot of less common types of IBD. We call this atypical IBD. And that would be things like the collagenous colitis, lymphocytic colitis, etc. These really can only be determined by biopsy and further investigation when colonoscopes and whatnot are done. We usually clinically don't talk about those as much, but we definitely, with these first two, this is the major category here. So let's look at some of the difference between the two. So we think that, let's start with Crohn's disease first. Crohn's we know is autoimmune. It has what's called the Th17 predominance. That's classic for a lot of autoimmune diseases like lupus and rheumatoid arthritis. It affects the entire GI tract, so anywhere from the esophagus, really the mouth, down to the anus, but most typically small intestine and the upper large intestine. It develops areas of what are called skip lesions. So you see areas of damaged mucosa in the small intestine. There'll be an area of normal mucosa, and then you'll see another area of inflammation. And the inflammation is transmural. It goes deep into the wall of the intestine. So if you look at the kind of intestine in cross-section, here's a normal intestine. Here is Crohn's disease. So you see a thickening of the wall, and that actually has to do with the inflammation triggering the smooth muscles to hypertrophy. It looks cobblestoned on the inside, and there are deep fissures and lots of scar tissue. And over time, it can become narrowed, and that can actually result in obstruction. And again, there can be areas like this can all be inflamed up to here maybe, and then a normal area, and then inflammation again here, and so forth. That's what they mean by skip lesions. We'll see in ulcerative colitis, it's really ulceration within the mucosa only. So you don't get that thickening, you don't get as much scarring as you do in Crohn's. Again, cobblestoning refers to that cobblestone appearance on the inside lining. And then this is formed because of granulomas. If you look inside the mucosa there's all these collections of white cells, specifically macrophages, that have all ingested each other, and they form a giant granuloma. Curiously, we see the same thing happen in tuberculosis in the lungs. So there's an interesting correlation. Is Crohn's due to chronic undiscovered tuberculosis bacteria? And there's some theories about that. We know that smoking worsens the outcomes in Crohn's. There's usually no gross bleeding, but we usually have a positive fecal occult blood test or FIT test. And the stools are often described as porridge-like, often with steatorrhea, indicating malabsorption of fat. Fever is common, so this is more hot and inflammatory versus the ulcerative colitis. Classic complications would be severe weight loss from the malabsorption. Fistula and stenosis are common, and that's going to be where an area, first of all, stenosis is going to be the narrowing of the gut lumen, but a fistula is where one part of the intestine, because of inflammation, let's say here's another part of the intestine that loops around, is going to actually form a passage between the two. So all this gets inflamed, and then a little passage forms. That's a fistula. These require surgery. And there's a higher risk of colon cancer and lymphoma with Crohn's disease. And the extraintestinal manifestations we talked about are less common than in ulcerative colitis. But again, the malnutrition is more common than ulcerative colitis. Ulcerative colitis we think is potentially autoimmune, but this one has more, it seems like a Th2 predominance, which is your main allergy branch of the immune system. We see the same thing in asthma and eczema and so forth. And I'll just say, jumping ahead, one of the things I often see with Th2 is a real lack of the adrenal steroid DHEA. So from a Chinese medicine perspective, we say this is a kidney qi deficiency. This is more of a deficiency pattern versus the Crohn's has more of an excess kind of nature to it, more fire and heat. The other thing about ulcerative colitis is it only affects the colon and the rectum. Rectum is always involved, but it can affect the colon all the way up to the ileocecal valve, but not the small intestine and the esophagus. And the lesions are continuous. So if it starts at the rectum, it extends to the sigmoid colon all the way up to the ascending colon. And as the lesions get higher and higher, the symptoms get worse and worse. So there's more and more diarrhea, more bleeding. And especially when it gets up to the splenic flexure and beyond, then we have very severe ulcerative colitis. The inflammation is superficial only in the mucosa. We get loss of the goblet cells and very deep abscesses that form in the crypts that can become infected. No granulomas like in Crohn's. And curiously, smoking actually improves the disease, and that's because smoking generally downregulates Th2 allergy immunity versus it actually upregulates Th1, Th17. So we'll see that also in the case of Hashimoto's and thyroid diseases. We get grossly bloody stools, often with mucus and tenesmus. So it's not just going to be the occult blood, the hidden blood that we have to use the fecal occult blood test to see, but it's going to actually be hematochezia, blood mixed in the stool, because it's again the bleeding starting in the rectum area, and then the inflammation is moving up. When there's fever, it's not typical with UC to see fever, but that's going to indicate very severe disease. Complications here would be anemia from all the blood loss and severe electrolyte loss, especially potassium. Fistula stenosis is rare in UC, and there is a very high risk of colon cancer here. So both are associated with cancer. Lymphoma a little bit more with Crohn's, but both are associated with colon cancer. More common extraintestinal manifestations here. So in the eye, uveitis, episcleritis, that's infection of the uvea, which is the outer kind of the middle protective portion. You can see iris inflammation and so forth. Erythema nodosum is a fat infection. These kind of inflammation in fat globules, not infection, but inflammation. Sorry, there's a difference. Infection is with the infective agent. Inflammation is just the inflammatory process. And in this case, it's just inflammation, not infection of underlying fat. Another condition called pyoderma gangrenosum. Oral ulcers, the aptostomatitis, arthritis, and especially ankylosing spondylitis is more common in UC. This is really where you get basically arthritis of the spine. So the spine begins to fuse, the spinal segments. And then thromboembolism, which is formation of a blood clot, which then so the blood is more susceptible to clotting, and that can form emboli, which break off, and that can create a stroke or pulmonary embolus or whatnot. And then sclerosing cholangitis, which is an autoimmune condition of the bile ducts, and that can cause narrowing. It's actually correct that it's an inflammation of the bile ducts, not necessarily autoimmune. So that's sclerosing cholangitis. So these are all what we call extraintestinal manifestations, more common in UC than Crohn's. Here's a table summarizing some of the differences in clinical presentation of Crohn's versus ulcerative colitis. So with Crohn's, the typical abdominal pain is going to be right lower quadrant. Can actually see strictures leading to obstruction, nausea and vomiting, or another potential sign of bowel obstruction. Lots more flatulence, bloating, and here's SIBO again. Diarrhea is going to be more prolonged but fluctuating. Less gross bleeding than in ulcerative colitis, and the severity is going to vary depending on what the lesions are. So if they're in the ileum, that's called ileitis, we get these large volume porridge-like stools. In colitis, that's inflammation in the intestine, smaller volume stools but more frequent. Perianal disease is going to occur in about a third, more than a third of patients. We get perianal pain and drainage from skin tags, anal fissures, perirectal abscesses, anal rectal fistulas. Fistula, again, very common in UC or CD, especially versus Crohn's. That's a tract that connects two epithelial-lined organs. There is a up to 50% cumulative risk after 10 to 20 years with Crohn's disease. Up to 45% develop fistulas before their diagnosis, and that's what actually leads them to go to the doctor. And the fistulas can connect not just to other portions of the intestine, like I had mentioned, but also to the skin, to the bladder, to the ureters and vagina. So you can actually get a fistula where the intestine actually creates a fistula between the colon or the small intestine and the vaginal wall, and then chyme and even fecal contents can come out of the vagina. That's a very severe manifestation, but that's possible. Abscesses are possible here as well. So again, this is more, this is a infected pocket, more hot, inflammatory. And the malabsorption is going to be a lot more common in Crohn's. So we can get what's called bile salt diarrhea, steatorrhea, gallstones, and severe malnutrition from those mineral absorptions. In the mouth, Aptus ulcers, the Aptus stomatitis like we talked about, cheilitis, inflammation, cracks in the lips, and that's going to be common to both Crohn's and ulcerative colitis. And then weight loss is common due to malabsorption and fasting. And fever is going to be less common, but usually it's going to be under 101 degrees if it's going to be present. With ulcerative colitis, it depends on the severity of the disease. So usually abdominal pain, diarrhea, rectal disease. Mild disease involves mostly just the rectum, and that presents typically with mild diarrhea, less than 4 loose stools a day, mild cramping, rectal bleeding with mucus. Moderate disease would be disease up to the splenic flexure, and that we call that left-sided colitis because it's going up the descending colon, and that has frequent up to 10 loose stools a day with passage of bloody stools as well, mild anemia, low-grade fever. And then severe is when it gets beyond the splenic flexure, often the whole colon becomes involved, and there's frequent loose stools, more than 10 times a day, severe cramping, tenesmus, which is cramping of the anus, bleeding, often requiring blood transfusion, and rapid weight loss. We can also see the inflammation extend beyond the mucosa to the other muscle layers of the colon in severe disease. So the colon begins to dilate. You lose the autonomic tone. That muscularis mucosa degenerates, and so it's not able to keep the right tone. And we get toxic, potentially toxic megacolon, potentially perforation, and then, but rarely the fistulas and the stenosis and the abscesses. And typically, comparing UC to Crohn's, we see in ulcerative colitis much more water and electrolyte deficiency and malabsorption as opposed to all the vitamins and everything else. So a lot less severe malabsorption in UC than in Crohn's. Weight loss is not going to be as common in UC as in Crohn's because of that. And fever, again, in UC is going to indicate more severe disease. And here I've just summarized the things we've already talked about, the extraintestinal manifestations. So we get the different arthritis, the eye complaints, the skin issues with erythema nodosum, pyoderma gangrenosum, and the cholangitis, different hematologic issues like increased risk of forming thrombi, and then pernicious anemia with the Crohn's because of the B12 malabsorption. Remember, the B12 intrinsic factor complex, which is made in the stomach, is absorbed in the distal ileum. So if there's severe damage to the ileal wall, you're not going to have proper B12 absorption. Then iron deficiency anemia, and then autoimmune hemolytic anemia can result as well. Osteopenia, osteoporosis, and then neurological issues, especially in Crohn's, You're going to see things like seizures, stroke, and whatnot, very severe disease. And that's often from the thromboembolism, but also potentially the B12 deficiency problems. So that's a big list. Again, patients are going to present differently, but hopefully by now you should start getting a little idea of the differences between ulcerative colitis and Crohn's disease. So our assessment for IBD, we'd be looking for clinical findings. We'd record our stool, consistency, frequency, blood, document any weight loss, consider your other organic disease. We were talking about IBD, so we don't need to put that in there. And then any, this would be celiac disease, really. We'd want to rule that out. And then looking at any family history, the effects of stress, medication, mood, and sleep again. Again, no definitive lab tests, but we check all the ones we've already talked about. So we kind of rule out all the things. So we look for celiac, look for other, we look for the fecal calprotectin, lactoferrin, which might tell us that this is more IBD. Look for potential pathogens like Giardia. In Crohn's, there are some antibody tests which are not commonly used, but they are used, and that is the PANCA and the anti-POMC antibodies. And these are more specific for Crohn's disease. And then colorectal cancer screening is, of course, important here. Here with Crohn's, we might do colonoscopy, but here the wireless capsule endoscopy might tell us more about the small intestine. And then for ulcerative colitis, usually this started with a flexible sigmoidoscopy. You have to be very careful about a colonoscope going up there. It could actually cause perforation in severe Crohn's. So they usually start with a sigmoid scope. They only go up to the sigmoid colon and then maybe progress to a full colonoscopy. Barium studies could be helpful, especially looking for strictures and fistula, and then the abdominal CT MRI for the same things. Our red flags here would be severe malnutrition, severe diarrhea, and all the other ones we've already spoken about. So that's the basic assessment. And again, if you have a patient that presents with any of this clinical history, clinical presentation, but they haven't had a formal workup, they should get one to make sure that this is not an inflammatory bowel disease and they need to get the appropriate treatment. So what is that treatment? Well, usually for the biomedical approaches, it is level 4 therapies, and that's going to be, number one, nutrient replacement. That's more of a level 3 therapy, but I put that here. Vitamins and minerals for Crohn's. But then the major medications would be either aminosalicylates. This is a variation of aspirin, and that's sulfasalazine and mesalazine. These are used for long-term management, and then typically for short-term, maybe bursts of corticosteroids to stop the immune process and to calm everything down. So high-dose corticosteroids are sometimes used short-term. Now, more sort of chronically, a lot of patients with Crohn's will need higher levels of immune suppression from this way of thinking. And so they use azathioprine or methotrexate, which are immunosuppressive drugs. And more common, a lot of gastroenterologists are now using biologics. Biologics target specific immune cytokines, TNF-alpha, IL-1, IL-6, and they either are antibodies that are injected and they bind to either the cytokine or to the receptor for that cytokine. And so that would be things like infliximab, adalimumab, and so forth. So all the MABs, there's a lot of them on the market now, and they all target different cytokines. But these are now being increasingly used for Crohn's. So this is like, you probably heard of Humira, and these drugs, that's what all this is about. And sometimes surgery is needed for obstruction, fistulas, and abscesses. Ulcerative colitis, the approach here is more electrolyte and potentially iron replacement for the anemia. Again, aminosalicylates, sulfasalazine, mesalazine. Corticosteroids for short-term use only. I've had several patients that just have like 20 bowel movements, bloody bowel movements a day, getting severely dehydrated and anemic. And really the only thing that takes them out of it is a short-term, usually 2-week dose of high-dose steroids. It's very important to remember when patients are on these high-dose steroids like prednisone, 60, 70, 80 milligrams, for more than a few days, they can't just stop those drugs cold turkey. So if they come to see you as an acupuncturist or whatever provider, and they're like, I just want to stop my steroid, they have to be tapered because that can result in severe adrenal collapse, and that could be fatal. So be sure that those patients finish the course. Usually the doctors will give them a tapering schedule, and they'll give them prescriptions for different strengths so they can taper off of that over time. Here again, immunosuppressives are being more increasingly used, as well as biologics, and then surgery. That's kind of a last-ditch effort to, once a patient hasn't responded to any of the therapies, but they're having severe loss of blood and electrolytes, they might need a portion of the large intestine removed. And that, again, is not curing the underlying immune problem, but it takes care of the immediate kind of danger picture. The typical step 1 therapies would be more simple elemental diet. Hydration. In Crohn's, usually higher fiber, less fats is more helpful. In UC, fiber can be an issue, so usually fiber is not emphasized. Exercise, sleep hygiene. Again, in Crohn's, smoking cessation is better. Usually, ulcerative colitis is less better for a period of time, usually a few months after smoking cessation. So that's not to say they shouldn't stop smoking, but no, there might be a flare-up in that time. And then CBT, relaxation therapy, these would be potential things. In terms of step 2 therapies, I have a lot of patients I work more with ulcerative colitis patients, but we have them on the ASAs. Sometimes they're on the biologics as well. They're still having some symptoms. And so here I'm addressing their pattern differentiation and their neuroendocrine system and so forth. And we usually see some really good results with that. So that is a way to think about the therapeutic order here with inflammatory bowel diseases. Okay, a couple other little conditions to be familiar with. One is colonic diverticulosis and diverticulitis. So colonic diverticulum is a little blind pouch in the large intestine wall. And you can see it in the picture over here. I'm drawing a red there. So it's really just like a weakening in the smooth muscle layer, and so you get this little pouch. That's called the diverticula. That is normal. A lot of people have them as they get older. So if you do a colonoscope, you can see a lot of these little pockets in the wall of the colon. And there's different reasons for that. One could be congenital. This is rare. So there's a congenital anomaly that can create that. But most of them are acquired. So it's very common, usually worsens with age or increases with age. By the age of 60, most people have, about half of people have a colonic diverticula, if not more. And we see that these are associated with a Western diet, interestingly, low fiber. So one theory is that the low fiber, but also all having lack of flavonoids, high saturated fat, all those things, and sugars, is creating a condition which is ultimately creating the diverticula. They mostly occur in the sigmoid colon, so down here. The mucosa and submucosa actually protrude into the places where small arteries actually enter the muscle layer of the colon. So again, not shown here is the mesenteric arteries that are sending their branches. Remember, they send the vasa recta, those straight vessels into here, and there are those arterial arcades, and these are all connected to the mesenteric artery. But basically where they enter, that creates a weakness in the wall here, and this is where the mucosa and submucosa pouch through. And so it looks like little balloons that are protruding through into the serosa. It's really uncommon in those eating more traditional diets, interestingly, so lots of grains, fruits, vegetables, and so forth. So it's mostly processed foods and foods low in fiber, especially insoluble fiber. And so one theory is that the stool gets more compacted, that creates more pressure and strain in the intestines, and that's why we get this outpouching. I'm not sure how well that supported that theory is, but that's kind of the idea out there. The treatment is to really increase fiber in the diet. Most cases are asymptomatic. Unfortunately, in some cases, the feces can become trapped in those little pouches. And one theory is that eating seeds and nuts and things like that don't get digested can plug up the hole there. I think that's been pretty much disproven, but that you still see that in the recommendations. And that can give overgrowth of bacteria now. And that creates a little abscess in there, a little infection. And then we have not just diverticulosis, not just having diverticula, we have diverticulitis. And so in diverticulitis, we get an actual infection. It looks like pus down in the intestine there and in one of those diverticula. And that's going to create more of a clinical concern. So here the diverticula become inflamed, a singular diverticulum, and typically we get fever, left lower quadrant, abdominal pain, maybe nausea. The assessment here is usually with a abdominal CT scan. We'll show those little infected pockets, and then maybe a right abdominal plain film X-ray. Barium enema, colonoscopy are contraindicated because they might actually rupture the colon. And you don't want that happening. So the complications are, again, rupture, and that can create peritonitis, hemorrhage, abscess, and then stenosis, a narrowing of that part of the colon due to inflammation, and then the scar tissue that builds up. So the treatment is, if there's no signs of bowel perforation, we recommend bed rest, pain management, fluid resuscitation, and patients are given broad spectrum antibiotics, and that can be treated outpatient. But if there's signs of bowel perforation, this is an immediate hospitalization, and they usually need surgery, sometimes to resect that portion of the bowel, debride the area, irrigate the peritoneum, and so forth. So typically, though, this kind of acute onset lower left quadrant pain with fever, maybe nausea, vomiting, if you're not a primary care physician and haven't handled this and so forth, then it'd be good to just refer that to the ED, and that can be treated appropriately. So that is diverticulitis and the more benign diverticulosis. Say a little bit here about appendicitis. This is the most common indication for abdominal surgery in children. Although it can occur in all age groups, it really peaks around the ages of 15 to 30. The clinical presentation is usually fever, acute onset abdominal pain, so it usually starts around the umbilicus, sometimes even in the epigastrium, but usually around the umbilicus, and over time it localizes to the right lower quadrant, an area called McBurney's point. McBurney's point is this indicated down here in this diagram. It's point number 1. It's basically this point, if you draw a line between the umbilicus and the anterior superior iliac spine, the part on the pelvic bone here, you draw a line between the two, and it's about a third of the way from the anterior superior iliac spine. So that's McBurney's point. That correlates with the peritoneum right over the appendix area. And so that's our classic kind of localization point. Now, a lot of people, again, the appendix is not well innervated with pain receptors, but as it becomes more and more inflamed and so forth, it's going to press and inflame the overlying peritoneum. And then we're going to start to be able to localize the pain. And that's why the pain often starts just kind of very generally in the peritoneum, and then it starts to localize there. Now, another important thing is with peritoneal irritation, we get rebound tenderness. So pressing, for example, on this side of the abdomen, pressing and holding and letting go, that creates a wave across the peritoneum, and that will exacerbate the pain. So that's another pretty characteristic finding. Patients usually have a lot of rigidity and gardening as well. Typically, they won't want to eat. There's vomiting, and often there's either constipation or diarrhea that results from that. And the pain can really ramp up pretty significantly over a couple of hours. So anybody that doesn't really have a history of abdominal pain, and they start developing these symptoms, this should be an urgent referral. Call 911 or get to the emergency room so this can be investigated. The differential diagnosis can be IBS, a flare of IBD, dysmenorrhea for menstrual cycle, ovulation pain, that would be mid-cycle pain, ruptured ovarian cyst, or ectopic pregnancy. So this is where an ultrasound can actually be very helpful in some blood tests. So that's why getting into an emergency department can be helpful. This is something, again, there's a difference between urgent care and emergency care. Urgent care can handle a lot of, minor aches and pains, the cold, urinary tract infections, things like that. But the emergency care is going to be able to get that person's surgical care. A lot of ERs have a CT scanner they can get a patient to. And so this is something you want to send for emergency care to the emergency room. The diagnosis is clinical. Again, refer to the emergency department if you suspect it. But labs that would typically show increased white blood cell counts. It would typically see white blood cells in the urine, and then even in the feces there would be white blood cells. We'd rule out pregnancy, so typically a pregnancy test is done for females. And then an abdominal CT is going to be your diagnostic test. So that's all going to be done in the ED. The treatment here will be surgical appendectomy. Now for older patients, and interestingly, depending on where you live, if you live in Europe, the guidelines kind of suggest antibiotic therapy first before surgery. But here in the US, typically the surgical options still are the predominant approach. But again, some patients, especially are too frail for surgery, may just need the antibiotic therapy. Complications, 40% rate of perforation in the pediatric population. So that's our big concern, is perforation of the appendix. And then it can spill fecal contents basically into the peritoneal cavity. That can create a massive peritoneal infection. Fortunately, though, with proper care, the mortality rate is very low, less than 1%. So just a little bit there to know about an acute appendicitis. Now, people can have chronic appendicitis where the appendix goes, acutely inflamed, then it kind of calms down. It wasn't removed surgically, then goes chronic again. Again, typically in the US, the solution is to remove the appendix in those cases. So that is appendicitis. Now, when it comes to cancers of the small and large intestines, first of all, I should say in small intestine, neoplasms or new growths, cancerous growths, are very rare. A neoplasm, I should be clear, specifies either a non-cancerous growth or a cancerous growth, but just a new growth. That's what it means, neoplasm. But those are rare in the small intestine. Large intestine has a lot of potential neoplasms. The good thing is most are benign. However, many of the benign neoplasms are pre-malignant, so they can become cancerous, but over usually years to decades, which is why there's time. But really, unfortunately, once these become cancerous and they start to invade the colonic wall, get into the lymph nodes, and metastasize, the prognosis rates really decrease. So usually it takes more than 10 years for a pre-malignant neoplasm to become malignant. Unfortunately, a lot of these cancers are not detected until they've already metastasized. Colon cancer is the number 2 cause of cancer death in the US, just behind lung cancer. And about 60,000 people die each year in the US. I'm not sure if that's from a few years ago, if that statistic is still accurate. Nearly all colonic malignant tumors are colonic adenocarcinomas. Remember, an adenocarcinoma is a carcinoma of mucosal glandular tissue. And again, they're present for at least a decade before becoming malignant. Colonic polyps, most of the growths in the colon are polyps. And that's a mass that rises above the mucosal surface, looks like a little mushroom. And it's some of them, the majority of them are benign. We call those non-neoplastic polyps. And some of them are what we call neoplastic polyps. They can become cancers. So they're called adenomas, and they can become adenocarcinoma. So the adenoma is benign, glandular epithelium, and the adenocarcinoma is a cancerous glandular epithelium. All right, so that is the kind of general introduction there. Now, in terms of non-neoplastic polyps, the ones that aren't cancerous, these are common after the age of 40, and they can be either sessile, they have a very broad, short base, or pedunculated. They look more like a mushroom on a stalk. You can have a condition called hyperplastic polyps, which are small, nipple-like foci of the mucosa. They're a few millimeters in diameter. They're the most common type of polyp, and they're often seen in the elderly in the lower colon and rectum on colonoscopy. Then there are juvenile polyps. These are polyp-shaped glandular malformations. They're a few centimeters in diameter. They're seen as a single lesion in children. Again, these are not worrisome because neither of them can become cancerous. The ones that can become cancerous are the neoplastic polyps or adenomas. And so they're potentially malignant. Over 50% of the people over the age of 50 have at least one, and that's why we start our colonoscopies usually at that age as screening tests. So the two most common types are the tubular adenoma or adenomatous polyp, and then the villus adenoma. That's going to be more of a sessile polyp. It looks fern-shaped, and these are much more malignant than the other ones. So the treatment's a little bit more aggressive and they can spread quicker. Size is the most important indicator of the malignant tendency. And the good thing is they grow very slowly over years, but importantly, as they grow, they start to bleed, and people develop iron deficiency anemia. And so iron deficiency anemia in adult men or a postmenopausal woman should always thought to arise from an intestinal cancer until proven otherwise. So we have to rule out intestinal cancers in those cases. And these go through different stages. So in stage 0, the cancer is localized, the polyp can just be removed, 100% cured. But in stage 1, 2, 3, 4, you see there's more invasion. Stage 4, we now have spread into the lymph nodes. Very difficult to treat that, and the prognosis is often very poor. A lot of those patients will present, and it's already metastasized to the liver. When you see a cancer in the liver, that's kind of an end stage. And I know there's a lot of discussion around that, but I've seen that so often in patients. By the time the cancer presents in the liver, I've not really seen people turn around in most cases from that. There are what are called polyposis syndromes. These are genetic disorders that can cause multiple colonic polyps, usually at young ages. So this is for people that have a family history of colon cancer. They often have one of these syndromes. And they often arise in the right colon, so the ascending colon. And so there's something called familial polyposis syndrome. It's uncommon, but the colon contains thousands of small polyps, and they can become malignant. And then there's several others. I'm not going to go through them. Gardner syndrome, Turcot, Poitiers, but these are all going to present with multiple polyposes, and these can all be pre-malignant. And so generally, if there's a family history of this, people will start getting colonoscopies at a much younger age, usually 40, if not even earlier, to detect these and then remove them before they become cancerous. So almost all colon cancers are adenocarcinomas, and they develop slowly from the colonic adenomas. And the kind of risk is what we call the two-hit hypothesis. You need more than one risk factor to really set things off. So one is just age. The older you get, again, after 50, over 50% of people have at least one colonic polyp, the adenoma. There could be genetics here, low fiber diets, inflammatory bowel disease, especially ulcerative colitis, and then any of the genetic polyposis syndromes. So usually having a combination of these is what's going to really increase your risk for developing colon cancer. Now they're going to present differently. The left-sided in the sigmoid colon cancers, usually they show early signs of obstruction, and they're going to be more symptomatic with altered stools and bleeding. They tend to form encircling tumors which constrict the bowel. And the, like on a barium enema or something, or barium swallow x-ray, they might find what they call a napkin ring or apple core constriction. Looks like the bowel is actually squeezed like a ring. There's a ring that squeezes it around here. With right colon carcinomas, there's really few signs until the tumor has already metastasized, and that would be all your classic signs of weight loss, abdominal pain, iron deficiency anemia, and so forth. Watery stools, and the tumors have more of a cauliflower-like. They're more sessile in appearance. And they spread on both sides. The tumors spread via invasion of the lymph nodes and blood vessels, and they typically metastasize to the liver, the lung, the peritoneum, and less commonly to the bone in the brain. About a third of cases are beyond cure at the time of diagnosis. So what's interesting is For a while, a lot of doctors were just doing sigmoidoscopy, looking at the sigmoid colon. So they caught a lot of these left-sided tumors, and those became less common, and then the right colon ones became more common. Now we're doing full colonoscopies. But unfortunately, we're seeing in younger patients, usually around 30, into their 30s, a real uptick in right-sided colon cancers. And this is kind of a perplexing thing as to why that's happening. But this is a big concern. And so we might see a change in the screening guidelines in the coming years because of that. In terms of staging of the cancer, it's always important to understand how severe it is and what kind of treatment is needed. The most common staging system is the Asler-Collar staging system, and it looks at the depth of the tumor in the bowel wall, the presence or absence of lymph node metastases, and the presence of any distant metastases. And so we have A through D basically. So A is limited to the mucosa. The 5-year survival rate is 100%. So if you're going to remove it in stage A, that's completely curable. Stage B, it's invaded the muscular wall, but the lymph nodes are negative. In stage B2, there's full penetration of the muscle wall with negative lymph nodes, and you see the prognosis rates are falling off 67%, 54% at 5 years. Stage C1, C2, there's full invasion of the muscular wall with positive lymph nodes. And finally in stage D, we have distant metastases, and the prognosis is very low. I think it's under 5%, 5-year survival rate. So again, the key to colon cancer is to catch it early and to really treat it appropriately. Again, our screening tests will be our stool occult blood. So we already talked about the FOPT and the FIT test. That can be repeated annually, usually starting at age 50. If they're positive, then usually that's going to signal the need for a colonoscopy. But typically the screening guideline is to start with a colonoscopy, usually a baseline at age 50. Again, earlier if there's a family history or other colon cancer risk factors. And assuming there's no polyps, usually the repeat is in every 10 years. But if there's polyps found or multiple polyps or something, the gastroenterologist might recommend coming back in 3 years or 5 years for a repeat colonoscopy. So colonoscopy is the gold standard. CT would be used to look for metastases like in the liver or other organs. And then there is a marker, CEA, that's secreted by colon cancers. We can't use it for diagnosis because it's non-specific. But once colon cancer is diagnosed, it can be used for monitoring. And then surgery and chemo are currently the major options for treatment. So that's colon cancer. Again, the key here is early detection. Finally, say something about a very common clinical condition we encounter, and that is hemorrhoids. These are fleshy swellings of the hemorrhoidal plexus. So basically that's the veins that are in the rectum, in the anal canal, sorry. The rectum's the part up here. We're talking here about the anal canal. And we have in the anal canal, remember the so-called pectinate line, and that line demarcates two different venous systems. One is this external venous system, and this drains into your systemic circulation. And then we have internal venous plexus, and that drains into the portal vein. And so we're going to see a difference between the different types of hemorrhoids based on which one is swollen here. Usually the hemorrhoids are they act normally as cushions to help with stool control, but they can become swollen and inflamed, and that's what a hemorrhoid actually is. They can enlarge and they can prolapse outside the anal margin. In about 40% of patients, they are asymptomatic. So 40% have hemorrhoids, no symptoms. External hemorrhoids originate below the pectinate line. One of the big differences here, so here's an external hemorrhoid, looks like a little grape hanging out of the anus, is that it's very painful. They usually cause few problems unless they develop a blood clot inside of them. That's called thrombosis, and they can become very painful. The good thing is they usually quickly resolve, and you might see a skin tag in that area after it heals. Another common symptom I see with external hemorrhoids is anal itching. So that's the external hemorrhoids. Again, the thrombosed ones are going to be more painful, but they usually don't need treatment except for just symptomatic. Sometimes sitz baths and things like that are helpful. Magnesium salts, Epsom salts, for example, can be helpful as a sitz bath. The internal hemorrhoids, a little bit more extensive. They originate above the pectinate line. They are painless, but they can cause bright red rectal bleeding during or after a BM bowel movement. So you can see blood in the toilet or on the surface of the stool. And then there's mucus discharge often. We can feel a perianal mass, and there's, again, itchiness. And a prolapse can actually cause fecal incontinence. So if it's large enough, it can affect the way that the internal sphincter muscle works, and that can cause a prolapse. We get fecal incontinence. There's 4 grades of severity of these internal hemorrhoids. So number 1, grade 1 is no prolapse. Grade 2 is prolapse with bearing down, but spontaneous reduction. Grade 3 is prolapse when bearing down and requires you actually stick the prolapse back up. And grade 4 is prolapse, and even with manual reduction, it doesn't stay up. And so these are the 4 grades of severity. The cause is actually unknown for hemorrhoids. We think chronic constipation, even diarrhea can contribute to that, low fiber diets, genetics, aging, obesity, pelvic floor dysfunction, pregnancy. I think there might be an endocrine aspect. I'm still looking into that. Androgens, for example, in males, low androgens might contribute to chronic hemorrhoids, etc. But those would all be some of the other things to maybe think about. The assessment would be pretty much from the history, physical exam, doing a digital rectal, and that anoscopic exam I discussed, and ruling out other important causes of rectal bleeding, so colorectal cancer, inflammatory bowel disease, the ulcerative colitis, diverticular disease, and then anal fissures. And then looking at other conditions causing an anal mass like skin tags, anal warts. This is a sexually transmitted disease. Anal warts is from human papillomavirus. There are different strains. They can actually predispose to anal cancer, and so that's something to investigate. Rectal prolapse, polyps, enlarged anal papillae, and then anal rectal varices, and that would be from portal hypertension affecting the internal hemorrhoids. Treatment here would be mostly for the lower grade ones conservative, so increasing fiber, sitz baths. Some evidence, little evidence of benefit though for topical suppositories, but symptomatically some patients benefit from that. There are, lidocaine, different types of things to numb the pain. Horse chestnut, stone root, which is in the mint family, witch hazel, all of these can act to strengthen the veins. We use them for varicose veins, but in this case can be potentially helpful for hemorrhoids. Yarrow and yarrow sitz baths have historically been used in the West for bleeding hemorrhoids to kind of stop the bleeding. There are different procedures. The little venous plexus can be ligated with a rubber band. That's called rubber band ligation. Sclerotherapy injects an agent into the venous system, which causes it to basically die and atrophy. Cauterization would be cauterizing it, burning it away. And then for grade 4 hemorrhoids, that would be surgical usually to correct that. So that's a little bit on hemorrhoids and how to maybe think about that. So that wraps it up for gastrointestinal pathology. In subsequent videos, we'll look at the pancreas, the liver, and gallbladder, and that will pretty much wrap up the block for the gastrointestinal system.